So we presented the BAC trial, biomarkers in acute cardiovascular care. In that study, actually, we investigated whether we can diagnose myocardial infarction faster and safer than by the EC guidelines recommended. So we did not wait for a 3-hour delay to measuring the next set of troponin values, but we did it already after 1 hour, and that was as safe as 3 hours. And the cutoff we did calculate performed better than the suggested 99th percentile by the EC and also by the ACC actually. So actually patients presenting with recent onset chest pain suggestive of acute myocardial infarction are really rising. There are a lot of patients in the emergency room and we need to discharge them. We need to discharge them as fast as possible, but obviously we want to have the highest safety for those patients being discharged without acute cardiac care. So we want to have a safe but also rapid algorithm to rule out myocardial infarction. What we actually did, we investigated 1,045 patients coming to our ER with suggestive acute myocardial infarction. Clinically, we diagnosed non-ST elevation myocardial infarction as requested by the EC guidelines. We measured a troponin T directly at admission, then waited for 3 hours, measured another set of troponin values. Integrating clinical judgment, imaging and ECG, we made the final diagnosis, NSTEMI versus no acute myocardial infarction. For study purposes, we measured a high sensitivity assay troponin I, another troponin assay. And we measured that directly after admission and already after 1 hour, so not waiting for 3 hours. We also measured it after 3 hours, but just for comparison. So we have a 3-hour algorithm as suggested, and our new algorithm is just shorter. We can rule out myocardial infarction after 1 hour. Today's assays are more sensitive than yesterday's assays. So with the old cutoffs, we couldn't be that sensitive, we couldn't be that fast. Today's better technology allows us to diagnose acute myocardial infarction faster with more sensitive and lower troponin I values. It's good for the patient and it's good for us because we limit the overuse of these scarce medical resources at the ER. We might even save costs, but we haven't analyzed that yet. It's another protein, but it's essentially the same. They're actually not available in the US yet, so they're not FDA approved, but they will become FDA approved now. We know a lot about that test, and the 10% coefficient of variation, which is an important marker of assay precision, is at 5.2. So below 5.2, the assay is not very precise. Above 5.2, it's very precise, and that's why we are happy that the cutoff was 6. So it's in the good area of that assay.